Thank you very much, Chairperson Sir Madam. I would be describing the antibody and T-cell responses to Cyanofarm vaccination in individuals in Sri Lanka. The dawn of the year 2020 was a turning point in our modern era and in global health. We have learned a hard lesson about the intrinsic vulnerability of our society to a single pathogen. It has crippled our economies, disrupted lives, livelihoods and social lives, and increased inequality of vaccination was quite evident. Chinese scientists sequenced the coronavirus as early as early 2020, and Sri Lanka detected the first case of coronavirus as early as January 2020. Scientists embarked on a race to produce safe and effective coronavirus vaccine in record time, which is the best and the safest way to control the COVID-19 pandemic. This slide highlights the three waves we experienced in Sri Lanka through three different variants. The first one was from B1411, that's the Sri Lankan variant. The second wave is from the Alpha variant. The third wave is from the Delta variant. As you can see here, the number of deaths also increased with Delta variant. Sri Lanka started slowly in the vaccination process. However, with increasing cases detected, Sri Lanka increased the vaccination drive, and as at today, Sri Lanka stands highlighted in the Asian region in par with the Western population with the rest of the world. Sri Lanka struggled to secure enough doses of vaccinations from the beginning. One of the available vaccine was Cyanofarm, which is an inactivated virocell-derived vaccine which is said to be effective. As there are limited data on immunogenicity, we investigated the immunogenicity of the vaccine in individuals in Sri Lanka. We recruited 323 individuals and followed them up prospectively for 6 weeks and compared the immune responses among individuals who got the natural infection. This slide summarizes the different methods we used in this immunogenicity study. Although we recruited 323 individuals, 41 individuals were found to be seropositive at the time of enrollment of the study. As I mentioned earlier, we checked the antibody levels via different methods. The first method was the total antibody levels. We checked the total antibody levels at 4 weeks, at 6 weeks in different age groups, and we found that more than 95% of the individuals were seroconverted following both doses of vaccination. Further, we went on to check the neutralizing antibody levels in this population, and we found that by 6 weeks, 81.25 of the individuals had ACE2 receptor blocking antibodies. Also, the ACE2 receptor blocking antibody titers 2 weeks after the second dose of the vaccine was similar to the levels we saw in the population who has got the natural infection. Antibodies to the receptor binding domain of the SARS-CoV-2 virus was assessed using hemagglutination test against wild type as well as different variants of concerns, namely alpha, beta and delta. We used 2 cohorts. The first cohort was the ones who were naive at the time of vaccination, and the second cohort was the ones who were seropositive at the time of vaccination. We checked the antibodies against wild type virus and different variants of concerns, and we compared the antibody responses against wild type virus with the other variants of concerns. We saw at 4 weeks in the naive population there was a significant difference between wild type virus versus beta and delta. However, at 6 weeks, we saw that there was a significant difference of the antibody production against wild type virus and with alpha, beta and delta. However, in the seropositive population at the time of vaccination, there were no significant difference between the variants of concerns except for beta, where we saw quite a significantly low levels of antibody production with the vaccine. Further, we went on to assess the correlation between the two neutralizing antibody tests, and we found that the two assays was highly correlated for the wild type virus. Ex vivo interferon gamma ELISpot assays were carried out at 4 weeks and as well as at 6 weeks for two groups of peptides in the S protein, namely S1 and S2. The S1 specific responses were significantly increased at 6 weeks compared to 4 weeks. However, this was not seen with S2 pool of peptides. In cultured ELISpot assays, even though the S1 appeared to have higher responses, this was not significant. The CD4 T cells demonstrated increased expression of CD107A than CD8 T cells at 4 weeks and as well as at 6 weeks. In contrast to CD107A expression, interferon gamma producing cells were significantly higher in CD8 groups compared to CD4 cells at 6 weeks. The number of antibody secreting cells were determined at 4 weeks and 6 weeks by B cell ELISpot assays, and we found that antibody secreting cells were significantly increased from 4 weeks to 6 weeks for S1, S2 as well as for N peptides. So ladies and gentlemen, this slide summarizes the Sri Lankan immunogenicity study with regard to Cyanofarm vaccination. As I have shown here, there are many unanswered questions which we have not answered through this study. I would like to acknowledge my co-investigators and funding agencies. Thank you very much.
Hello everyone. Thank you for the opportunity to present my abstract on non-Ige mediated anaphylactic reactions to a Pfizer COVID-19 vaccine. Now, this is a background or timeline of events that occurred on the 11th of December 2020. The US FDA granted the emergency use authorization of the Pfizer vaccine, and by 6th of January 2021, the CDC announced that there had been 21 cases of anaphylaxis from the Pfizer vaccine. Now in Singapore, the HSA granted the interim authorization for the Pfizer vaccine on the 14th of December and the Moderna vaccine on the 3rd of February. And on the 5th of July, the HSA reported 42 cases of anaphylaxis nationally amongst 5 million overdoses of mRNA vaccines administered. So this is a case report that we put up of one of the first 3 cases of anaphylaxis that we saw in our institution. And we note that all these patients have normal tryptase levels. They have high C3A levels that were collected 3 to 6 hours after the reaction. And the C3A levels do drop over time. Because most of these cases of anaphylaxis have normal tryptase level, we were wondering whether they are actually non-Ige mediated. So we tried to look into whether they are activated via the complement or antibodies. Now this table shows all the ingredients included in the Pfizer and Moderna vaccine. And of interest, the PEG that's bound to the lipid nanoparticle is one of the most talked about ingredient or culprit that could cause some of these allergic reactions in COVID-19 vaccine. as shown in this diagram here. The pre-existing anti-PAACI IgE antibodies can bind to mast cells leading to classical anaphylaxis, or there can be activation of complement with or without pre-existing anti-PAACI IgG or IgM, leading to CAPRA or non-classical anaphylaxis. So in our institution, our clinical immunology laboratory receives nationwide tryptase samples, and from January to 2nd of March 2021, our lab receives samples for 32 patients who developed immediate hypersensitivity reactions to the Pfizer vaccine. And we know that these patients reacted to the Pfizer vaccine because the Moderna vaccine rollout only started on the 17th of March 2021, and there were no other COVID-19 vaccines that were available in Singapore at that time. So we noticed that all the tryptase samples from reactions to the Pfizer vaccine are normal. And we use remaining sera from these samples to test for anti-PAACI antibodies, C3a, and cytokines. Now, we tried to develop our own in-house assay to detect IgG, IgM, and IgE antibodies to the Pfizer vaccine. And we used 6 participants who have not received the COVID-19 vaccine as controls, and we termed them the vaccine-naive group. So in this graph, we found that a number of patients' tryptase samples have very high PAACI IgG antibodies compared to the vaccine-naive group. And as for the anti-PAACI IgM antibodies, there appears to be a slight increase compared to the vaccine-naive groups. So the anti-Pfizer IgG and IgM is our in-house assay employing the whole Pfizer vaccine as capture antigen. And these assays allow for measurement of all immunogenic epitopes that can potentially trigger an IgG, IgM, or IgE response. So there are a number of tryptase samples with very high anti-Pfizer IgE and IgM antibodies. We could not detect any anti-IgE antibodies in all of these samples, despite using two different anti-human IgE reagents. So this pictorial shows the in-house assay that we developed, where the whole Pfizer vaccine was added on the plates as capture antigen, and the patient's sera was being added in, and a secondary antibody conjugate consisting of either anti-human IgG, IgM, or anti-IgE was added, and subsequently there was a substrate added to see if there was a color change. So in the tryptase samples, we noticed that they also have high C3a levels compared to the vaccine-naive groups. We noticed that there are 2 distinct cytokine patterns observed in all the tryptase samples. So close to half of the samples exhibited enhanced Th2 cytokine profile with high levels of IL-4, IL-33, and IL-10. Now we tried to see if there was a relationship between some of these antibodies and IL-4 levels, and whether the antibodies could be the ones triggering the cytokine levels. So when we classify the patients via the IL-4 levels, we find that those with high IL-4 levels appear to have higher levels of IgG and IgM antibodies. So in conclusion, our preliminary findings show that anaphylaxis to the Pfizer vaccine is unlikely due to IgE-mediated mast cell mechanisms. The vaccine reactors have normal tryptase levels, but instead they have high C3a levels that drop over time. Now, some of these vaccine reactors also have high IgG and IgM antibodies to PAACI and the Pfizer vaccine, as well as high Th2-related cytokines. Now, I think further studies is required to determine the immunological mechanisms behind anaphylaxis to the mRNA COVID-19 vaccines. Larger cohorts or patients, participants are required also to determine the prevalence of anti-PAACI, anti-Pfizer antibodies, as well as whether these antibodies have a role in triggering some of these reactions, as well as to establish a cutoff value. Thank you.
Hello, everyone. My name is Valerie Chiang, and I'll be presenting on COVID-19 vaccine allergy safety in Hong Kong. The vaccination program remains the most hopeful strategy to end the COVID-19 pandemic. However, there were also reports of an unprecedented rate of vaccine-related anaphylaxis, upwards of 10 cases per million doses, more than tenfold compared to traditional vaccines. This led to a surge of public concern regarding COVID-19 vaccine allergy safety and grounded vaccine uptake in many countries across the world. Fortunately, the Hong Kong Institute of Allergy's first set of consensus statements on COVID-19 vaccine allergy safety allowed Hong Kong to experience a much lower rate of anaphylaxis. As of today, less than 0.5 cases per million doses. However, the lack of allergy specialists has led to huge waiting times in both private and public sectors, which aggravated public dissatisfaction and vaccine confidence. To address the pressing concern between vaccine allergy safety versus uptake, we performed the study to distill Hong Kong's local experience and further refine our VAS recommendations. Hong Kong University and Hong Kong Sanatorium and Hospital performed this multi-center public-private interface study to review the experience of the first 4 months of COVID-19 vaccine allergy safety in Hong Kong. Our combined cohort totaled to 1,127 patients referred for concerns about COVID-19 vaccine allergies. We collected a comprehensive data set including patient demographics, waiting time, pre- and post-vaccine status, indications for referral, and allergy testing performed, etc. Prospective data was also collected to analyze outcomes post-allergist consultation. Association analysis was performed to identify vaccination safety, vaccination outcomes, risk factors for vaccine-associated allergy, and waiting time. Our study generated a plethora of important clinical findings, which will soon be available in our full paper. Key findings can be summarized into 3 main points. Firstly, COVID-19 vaccination is very safe. 98% of so-called high-risk patients were recommended to get vaccinated. Follow-up interviews identified that 80% received their jabs without problems. The remaining 20% were still reluctant despite recommendation, but there were no adverse vaccine outcomes. Out of those 2% who were recommended to defer vaccination, 86% of these were due to an inability to rule out excipient allergies, all with suspicious drug allergy history. Secondly, in line with emerging evidence across the world, association analysis revealed that history of so-called anaphylaxis or even multiple food allergy, drug allergies, were not associated with a higher risk of vaccine-associated allergies. Lastly, and more locally relevant, we identified multiple problems in Hong Kong's healthcare infrastructure. At our Hong Kong University VAS clinic, there were more than 2,500 referrals in June alone, but 45% of these referrals were deemed inappropriate, meaning there was no indication or not sufficient information. Even if referral letters passed our screening stage, we found that 56% of so-called anaphylaxis patients did not meet anaphylaxis criteria on review. This highlights the huge deficits in Hong Kong's allergy care and referral system. We are proud to announce that our study has made far-reaching changes in COVID-19 vaccine allergy safety and literally transformed the vaccine campaign since this month. From our unique local experience, we have now updated our COVID-19 vaccine allergy safety consensus statements in Hong Kong. This has been fully adapted by the Department of Health. For example, patients with history of anaphylaxis and food allergies can now be vaccinated in Hong Kong. Acknowledging deficits in pharmaceutical legislation regarding excipient disclosure, patients with risk of excipient allergy can receive non-PEG-related vaccines. For suspected post-vaccine cases, the vaccine centers now encourage second dose after minor reactions, after data showing most patients can receive second dose of vaccine safely. Now, knowing that allergist care is not required in the majority of referrals, the hospital authority established its 7-cluster vaccine allergy safety hub and spoke clinics to help clear the 7-year waiting time at our vaccine allergy safety clinic. We have also used our safety data to frontline staff under the Department of Health, hospital authority, and public sector to empower our colleagues to help in promoting vaccine allergy safety in a true interdisciplinary. I would like to dedicate this last and most important slide to thank all our collaborators and partners that have made this incredible journey possible. A silver lining of this pandemic has been an opportunity of allergy care to flourish and strengthen our interdisciplinary connections. We hope our study continues to lay the foundation of future studies and healthcare reforms, which will improve allergy care for all of our patients. Thank you.
Good evening everyone. I, Dr. Richa Udwani, resident in Department of Pulmonary Medicine, GMERS Medical College and Hospital, Gotri, Vadodara, here to present a paper on assessment of pulmonary function test in patients recovered from COVID-19 infection.
Introduction. Coronavirus disease, as we all know, is a contagious respiratory and vascular disease caused by SARS virus. Common symptoms include fever, cough, fatigue, breathing difficulties, and loss of smell and taste. While most of the people have mild symptoms, some people develop acute respiratory distress syndrome. ARDS is precipitated by cytokine storm, multi-organ failure, septic shock, and blood clots. COVID-19 due to SARS virus includes multiple organs, and lung injury is one of the most common clinical manifestations. SARS virus entry into the lungs occurs by the angiotensin converting enzyme receptors expressed by the type 2 pneumocytes, which will lead to acute inflammatory response and cytokine storm production, which will lead to the activation of the resident dendritic cell and T lymphocyte production, which will lead to the release of cytokines in alveolar septa and the interstitial compartments. Interstitial inflammation, diffuse alveolar damage, and necrotizing bronchitis occurs as a result of cytokine production, which will lead to the fibrin deposition, formation of hyaline membrane, type 2 pneumocyte proliferation, granulation tissue formation followed by collagen deposition. All the above pathology leads to severe scarring and fibrosis, which will lead to the impairment of the diffusion capacity and restrictive ventilatory diffusion. COVID-19 also leads to the impairment of the respiratory muscle by the inflammatory process, which is aggravated by the loss of muscle mass from immobilization, generating motor disabilities. There are studies underway for muscular strength assessment in post-COVID pneumonia patients. With this background, we have designed this study to assess pulmonary function and symptoms in patients with post-COVID pneumonia. Objectives include to assess the pattern of pulmonary function in patients infected with COVID-19 and correlate with the symptom, to assess the respiratory muscle strength in patients after COVID-19 infection. Inclusion criteria includes age more than 18 years, previously confirmed COVID-19 positive report, completed 1 month after positive, willing to participate and give consent. Exclusion include not able to perform the pulmonary function test, patients in moribund condition, patients with active viral infection, patients having old pulmonary tuberculosis, asthma, COPD, ILD, and chronic respiratory diseases, patients having chronic diseases like HIV, malignancy, etc. Methodology: 101 patients who gave consent to participate in the study and fulfilled the inclusion-exclusion criteria were enrolled for the study. Patients were assessed based on the respiratory symptoms like cough, breathlessness, weakness, and limitation in activity. After symptom assessment, pulmonary function test was performed after 1 month of the positive report, and correlation of the symptom severity and pulmonary function was done for all the enrolled patients. Moving on to the results, we can see that though 49 patients had no ventilatory defect, DLCO was reduced in 53% of these patients, that is about more than half of the patients. Here, FEV1 correlation with the symptoms was done, and we can see that though 53 patients had none symptoms, but FEV1 was reduced in around 30% of the patients. Here, FVC correlation with the symptoms was done, and we can see that out of the 53 patients having none symptoms, FVC was reduced in around 41% of the patients. Here, DLCO correlation with the symptoms was done, and we can see that out of the 12 patients having both weakness and dyspnea as the complaint, DLCO was normal in none of the patients. Out of the 11 patients having weakness as the only complaint, DLCO was normal only in 2 patients, that is around 18%. Out of the 25 patients having dyspnea as the only complaint, only 4 patients, that is around 16% of the patients, had normal DLCO. Hence, DLCO does correlate with the symptom of the patients, and it is the most sensitive of all the other parameters. Here, MIP comparison with the symptoms was done, and we can see that 53 patients having no symptoms, MIP was normal only in 4, that is 8% of the patients. Out of the 12 patients having both the symptoms of weakness and dyspnea, MIP was normal only in 1, that is 8% of the patients. Out of the 11 patients having only weakness as the complaint, only 9% had normal MIP, while out of the 25 patients having dyspnea as the only complaint, no patient had normal MIP. Similarly, for MEP, correlation of the symptoms was done, which shows that out of the 53 patients having none of the symptoms of weakness and dyspnea, only 5 patients had normal MEP. Out of the 12 patients having both symptoms of weakness and dyspnea, only 17% of the patient had normal MEP. Out of the 11 patients having only weakness as the complaint, only 2 patients, that is 18% of the patients, had normal MEP. While out of the 25 patients having only dyspnea as the complaint, no patient had a normal MEP. Hence, MIP and MEP are more sensitive but less specific. For MVV, out of the 53 patients having no symptoms, it was normal in 44, that is around 83% of the patient. While 12 patients having both weakness and dyspnea as the complaint, it was normal in 75% of the patients. Hence, MVV is more specific but not so sensitive. Also, it is time consuming and cumbersome for the patients to perform. Hence, MIP, MEP and MVV are not much useful.
Discussion: very few studies have been done on pulmonary function test in post-COVID patients. The results of the previous study are consistent with the present study, which shows that diffusion lung capacity is most commonly impaired. In the present study, we have seen that 69% of the patients had reduced DLCO. There are no previous studies done which correlate the pulmonary function with the symptom severity. We can see from the previous study that 52% of the patients had reduced DLCO
and 47% of the patients had reduced DLCO. Conclusion: hence, DLCO is the most sensitive test for evaluation of pulmonary function in post-COVID patients, and it does correlate with the symptom. MIP and MEP are more sensitive but not so specific. MVV is specific but less sensitive. Hence, spirometry and respiratory pressures are less useful as compared to DLCO in post-COVID patients.
Thank you.
Hello, my name is Rei Kanai. Today I'd like to talk about real-time surveillance of adverse events following COVID-19 vaccines. I have no COI. To overcome COVID-19 pandemic, several effective vaccines has been developed and hope for eradication of SARS-CoV-2 is on the horizon. However, high incidence of anaphylaxis and other adverse events following the vaccine has been observed. We developed a web-based real-time surveillance system to monitor all AEs following COVID-19 vaccines. Hereinafter, this is called COV-SAFE. We examined an immediate allergic reaction to COVID-19 vaccine using COV-SAFE. First, I'd like to briefly explain about COV-SAFE. We employed a social media platform to develop the system. COV-SAFE electronically delivered questionnaires asking possible risk factor for allergic reaction to the subject before the first dose COVID-19 vaccine. Based on the answer to the questionnaire, different caution messages to the subject are sent to assure safe message after vaccination. The system then sent message to incur any symptom occurred after vaccination at 30 minutes, 2 hours, 24 hours, and every day until the second dose. After the second dose, surveillance of AEs is continued in the same way. Answers to the queries are continuously collected in the core database, and summaries of the AE data are simultaneously published at our website. Data registered to COV-SAFE from February 12 to September 5, 2021 was extracted for the current analysis. Frequency of AEs were calculated and multiple logistic regression models to predict the occurrence of immediate allergic symptoms were constructed based on collected information. Here, the background information we collected are shown: age, gender, history of allergic reaction to vaccine, drug, polyethylene glycol, and others. history of COVID infection, comorbid allergic disease, especially uncontrolled asthma, and personal attitude toward vaccines. Then presence or absence of symptoms after the vaccination listed here were asked. In this study, we analyzed the symptom marked in red that occurred within 30 minutes after vaccination. About 14,000 subjects was registered to COSAFE. Of them, about 9,000 people responded after the first dose, and about 7,000 responded after the second dose. 69.2% of participants was female. Because initial vaccination campaign was performed for medical professionals and many nurses were females. Likewise, young working population was predominant and the mean age was 39.5 years. Prevalence of history of allergic reaction to drug, vaccines, and others, uncontrolled asthma, and possible psychological reaction are listed in this slide. About 2 to 3% of participants had history of allergic reaction to medication, any skincare product, and common allergen such as food. History of allergies to vaccine and polyethylene glycol was rare. Uncontrolled asthma and possible psychological reaction to injectable were 2 to 3%. Here, I show symptoms occurred within 30 minutes after vaccination. Prevalence of each symptom was about 0.1 to 0.3% at the first and second dose, and any immediate allergic reaction was about 1.0%. We then sought risk factor for each symptom by logistic regression analysis. Statistical significant variables are shown here. You can see that the history of vaccine allergy was demonstrated to have high odds ratio in many symptoms. Uncontrolled asthma showed high odds ratio for occurrence of cough and wheezing. Limitation of this study are: first, due to questionnaire survey, all symptoms were subjective and non-objective signs symptoms were surveyed. Thus, instance of anaphylaxis based on case definition by Brighton collaboration was not known. Second, the number of symptoms for the second dose may be lower than the actual number because some people did not receive the second dose because of the first dose COVID-19 vaccine reaction. Delayed reactions are not under investigation. In conclusion, adverse events to COVID-19 vaccination were analyzed using a web-based questionnaire. The frequency of immediate allergic reaction was 1% for the first dose and 0.95% for the second dose, both around 1%. Generally, the vaccines were well tolerated and safe. Patients with a history of allergic reaction to previous vaccine, drug, food, Hemoptera venom, latex, or uncontrolled asthma within 1 year were at risk for immediate allergic reaction to COVID-19 vaccination. Thank you for your attention.
Hello friends, good evening. I am Dr. Neil Patel, resident in Department of Pulmonary Medicine, GMERS Medical College and Hospital, Gotri, Vadodara. Topic of my paper presentation is to assess CT chest finding of post-COVID pneumonia patient. COVID-19 is an infectious disease caused by severe acute respiratory syndrome coronavirus 2, a strain of coronavirus. The first case were seen in Wuhan, China in December 2019 before spreading globally. COVID-19 typically presented with fever, cough, shortness of breath, loss of taste and smell sensation, fatigue, sputum production. During viral lung infection, lung histologically shows diffuse alveolar hemorrhage, interstitial lymphocyte infiltration, edema, type 2 cell hyperplasia, hyaline tissue formation. The characteristic features of CT chest finding in post-COVID-19 pneumonia patient during recovery phase: ground glass opacity, intralobular and interlobular septal thickening, traction bronchiectasis, parenchymal bends, and consolidation. Other finding: cavitation, thrombi, or emboli and nodules also seen in post-COVID patients. However, there is paucity of data regarding long-term CT chest finding of current post-COVID-19 pandemic patients. Objective of study to assess CT chest finding of post-COVID pneumonia patient in current pandemic. Method of study, prospective observational study 1 month after COVID-19 pneumonia. 100 patients recover from COVID pneumonia were assessed 1 month after recovery. These patients were assessed based on their chest CT finding like ground glass opacity, intralobular and interlobular septal thickening, traction bronchiectasis, parenchymal bends and consolidation in post-COVID after 1 month of recovery. Inclusion criteria for this study. Age should be more than 18 years, willing to participate and give consent. All subjects recover from COVID-19 pneumonia. Exclusion criteria for the study. Age less than 18 years, HIV AIDS, active and all pulmonary coughs, malignancy, bronchiectasis, and interstitial lung disease and other chronic respiratory conditions. Results. As we can see that ground glass opacity were present in almost all patients, about 97% even at the end of 1 month. The most common finding after ground glass opacity was interlobular septal thickening 79%, followed by parenchymal bends 54% and traction bronchiectasis 48%. Consolidation was seen in 37% patients. Out of all patients, only one patient had a normal CT finding. This table is about extent of lung involvement in all patients. Out of 100 patients with ground glass opacity, 94% patients had bilateral lung involvement. Only 3% patients had right lung involvement. Unilateral left lung involvement was not seen in any patient. Out of 100 patients with ground glass opacity, 79% patients had a involvement in all 6 lobes, while only 2 patients had single lobe involvement. In 88 out of 100 patients, CT chest was done between 1 to 2 months after COVID-19 infection. Discussion. These are studies done previously. Study published by Nestor L. Muller et al. In July 2003 about CT chest finding in severe acute respiratory syndrome, and another study about CT chest finding in Middle East respiratory syndrome by Ryan in October 2014 and Ahmed in December 2014 suggests that the most common CT chest finding is bilateral ground glass opacity or consolidation. But in our study, multifocal bilateral ground glass opacity or interstitial thickening were most common finding. Another study done in January 2004 by Monica SM about HRCT finding in patients with severe acute respiratory syndrome and Davidong and 2016 August about thin CT chest finding in severe acute respiratory syndrome suggests that most common CT chest finding is bilateral ground glass opacity or interstitial thickening, and these study findings are consistent with our study. So final conclusion, bilateral multilobar ground glass opacity are most common presentation on CT chest finding even after 1 month of COVID-19 infection. Interlobular septal thickening, traction bronchiectasis and parenchymal bends are also frequently early presentation even before 1 to 2 months. Thank you.
Ladies and gentlemen, I'm Dr. Chai from the Department of Pediatrics, Changhua Christian Children's Hospital. My present topic is the impact of particle 2.5 exposure on airway inflammation in school children near coal-fired power stations, a population-based study. Changhua County is the central part of the Taiwan. As we know, nitrogen oxide, which is synthesized from the left arginine by inducible anal synthesis, iNOS, is main produced by the epithelial and the inflammatory cells in the inflammatory airway disease. Fluorescence in whole nitroxide is a non-invasive serine biomarker of air inflammation for diagnosis and follow asthma. Its level of phenol correlates with eosinophilic inflammation and asthma severity in uncontrolled asthmatic children. Phenol values decrease after inhaled corticosteroid and can be a biomarker in a clinical practice. Personal and environmental factors may influence phenol levels, including age, gender, and race. In addition, nitrogen intake, tobacco smoking, and outdoor and indoor air pollution also affect on phenol levels. There is growing evidence of significant association between the phenol levels and air pollution. Meta-analysis of epidemiologic study report the positive association between the short-term naval air pollution exposure and the phenol levels. However, the lack data for long-term air pollution exposure on phenol levels, especially on children's respiratory health. So the object of study, we evaluate the association of air pollution exposure with respiratory symptoms on phenol levels in school children near coal-fire-based power plants. We enrolled 7,808 of school children aged from 8 to 13 years residing in the 4 higher air pollution exposure townships near coal-fire-based power stations and 3 control townships in Taiwan. Asthmatic symptoms and the environmental questionnaire and the phenol measurement were evaluated. Annual personnel particle PM2.5, nocturnal exercise, and sulfur dioxide exposure was estimated using the monitor in the children's school and the central site EPA stations. By then use regression model using the data on children's school and the home addresses. 2 air pollution research areas in Changhua County were classified, including the North Industrial Townships, Sengang, Xianxi, Hemei, in the northern part of Changhua County, near the Taichung coal-fired power plants, and the South Industrial area, located near the petrochemical coal-fired power plants, and the urban, the agricultural township, Puxin, Sengang, and Xizhou was selected in the control group. Then use regression model and the student exposure from the children in the home setting with 8 hours per day and 16 hours per night respectively. Each pollutant exposure, including the PM2.5, sulfur dioxide, and the nitrogen oxide, was estimated and the annual average exposure using the G-coding school and the home addresses. This is the scheme of enrolled flow charts. A total of 6,808 children were approached, and the final study population was 619 school children. Response rate with 93.4%. And finally, data of 1,138 school children who completed the questionnaires and the phenol measurement were the final subject to analysis. The core of the ISAC questionnaire in about the past question was 15.3%, and the current width was 5.72%, and the diagnosed asthma was 6.23% in the all study populations. This is the demographic and the individual category characteristic of the study subjects living in the industrial and urban cultural townships. And the response for asthma and the related questionnaire, we can find it, the prevalence of the past width and the current width, had signaled in the industrial townships, including Zone 1 and Zone 2, when compared to urban agricultural township. Children living in the Zone 1 township with high annual PM2.5 exposure significantly increased the phenol levels by the multiple variant analysis. This data showed the phenol was positive association to age, past with allerginitis, eczema, and in the exposure PM2.5 townships. To detail the potential effect on the phenol level due to the air pollution exposure, we conduct stratified analysis to the covariate, the association PM2.5, the nitric oxide, and the sulfur oxide exposure among all participants. After just for the potential confounding factor, each increase 1 microgram per kilometer PM2.5 exposure was signal association with the 0.6 increase percentage in the phenol levels. Our result further the classification by the dichotomy analysis of all the participants by the annual PM2.5 exposure, and we could find a trend. The high annual PM2.5 exposure had increased the trend of the history of nasal problem, allerginitis, itching eyes, and the high phenol exposure. This is the study conclusion. The asthmatic symptom of past wheeze, current wheeze, significantly increase the children living in high air polluting townships. In the multivariate analysis, phenol level are positive associated with AIDS, past wheeze, allerginitis, eczema, and the reason in high PM2.5 exposure areas. At the control the confounding factor, we observe annual PM2.5 exposure had a significant increase the phenol levels. Using the phenol level in population-based epidemiology research provide evidence concerning the impact of the PM air pollution on children's respiratory health and airway inflammation. Thanks for your attention. The WHO goal, the sustainable development is the clean energy. There are many wind generators in the Changhua County coast. Welcome to have the tour after the COVID-19 pandemic. Thank you for attention.
Hello, everyone. Nice to meet you. My name is Myung-sun Song from South Korea. It's my honor to have opportunity to have oral presentation in front of you. Today, I'm talking about an association between serum vitamin D level, phenol, and bisphenol A in children. Is disclosure. To start to read, look at this screen background. We will know about bisphenol. What is bisphenol? Bisphenol is a compound present in many plastics that can be disturbed the endocrine system. According to the center investigation, bisphenol A is associated with an increased level of the phenol, but this relation is controversial. Thus, further evaluation are needed to come to association between bisphenol A and phenol. This screen is about vitamin D. Vitamin D moderates the reverse immune pathway that function in airway function and inflammation. So, vitamin D potentially affects the association between bisphenol A and phenol. Thus, studies are needed to identify the immunomodulating effect of vitamin D on bisphenol A exposure and the lung function and the phenol in children. To our knowledge, unfortunately, no previous study examined whether vitamin D affected phenol and the small airway function in children from the general population who were exposed to bisphenol A. So, we investigated the effect of vitamin D in moderating the relationship of bisphenol A with phenol and small airway lung function. This slide showed how we process this study. This generation population-based cross-section study of children who were 10 to 12 years old age from elementary school in Seongnam City was conducted from June to July 2017. A total of 432 children had parents who returned the completed questionnaire and agreed to supply sample blood and urine. Also, they agree measure of phenol and the IOS. So, pediatrician and well-trained pediatric technology visited their school, and we conducted the physical examination and all tests at school. We first analysis the character of all 432 participating children. To look at table, you can easily understand. There were 233 males and the mean age of 11 years. The mean urinary bisphenol A level was 2.75 and the mean serum vitamin D level was 24.1. The serum vitamin D level was normal in 34 children, but insufficient and deficient children is over 80%. The mean phenol was 60 ppb. We examined the relationships of serum vitamin D, urine bisphenol A, and indicators of small air function, includes total airway, small airway, and phenol. The result indicated that serum vitamin D level enumerated the effect of bisphenol A on phenol in adjusted analysis and in adjusted analysis. However, vitamin D had no other moderate effect in adjusted and in adjusted analysis. To look at this slide, you are curious about the definition of the margin effect. A margin effect is amount of change in dependent variable, in this case of phenol and the IOS parameters, when there are change in independent variable. In this case, vitamin D level. To look to figure, a margin effect is amount of change in phenol and IOS parameters when there are change in serum vitamin D level, and the marginal effect of serum vitamin D level was 23 in this study. And now you can easily understand the definition of margin effect. I hope you all understand the definition of the margin effect. A little difficult concept. To look at this table, you can easily recognize, according to serum vitamin D level under 23 or over 23, the association between serum vitamin D, urinary bisphenol A, and iOS level of phenol are showed in this table. After adjustment for compounding, serum vitamin D, urinary bisphenol A levels was associated with phenol in children with a serum vitamin D level under 23. Also, the phenol was associated with allergy disease and mono and polysensitization in children with serum vitamin D under 23. However, after adjustment for compounding the bisphenol, the phenol was associated with mono and polysensitization in children with the level of 20, vitamin D level over 23, but not RS and urinary bisphenol A levels. From now, I will explain my study conclusion. Number 1, our study indicated that the urinary bisphenol A and the serum vitamin D level were significantly associated with the phenol in those with a serum vitamin D level of 23 or less, but had no association with the phenol value in those with a serum vitamin D level of 23. Number 2, phenol appear to have a different relationship with exposed to bisphenol A, depending on vitamin D status and the presence of allergy disease, such as asthma and allergic rhinitis. Number 3, this point indicates the increased exposure to bisphenol A and low vitamin D level were associated with increased airway inflammation and elevated phenol. It's my last slide. In conclusion, high urinary bisphenol A and low serum vitamin D levels were significantly associated with airway inflammation in children. Furthermore, serum vitamin D levels ameliorated the bisphenol A mediated increase of phenol. Thus, reducing exposure to bisphenol A and increase vitamin D level in children may help prevent airway puncture.
Hi everyone, I'm Yu Hanxin from the Chinese University of Hong Kong. I would like to express my gratitude to the conference committee for organizing this wonderful event and providing me this opportunity to share our research with you. I really wish to see you in person, but I believe the conference committee have made a wise choice considering the current COVID-19 situation. My topic today is a possible mechanism of rural protection against childhood asthma through inflammatory signaling pathways. And I'm presenting our project on behalf of our research team from the Chinese University of Hong Kong, Guangzhou Institute of Respiratory Disease, and MMU Munich. In relation to this talk, I have no conflict of interest to declare. Up to now, the exact causes of asthma still remain unknown, but one of the most consistent findings is that living in a farming or rural environment protects children from asthma and allergic diseases. In this map, the regions painted in blue represent different parts of the world where comparative studies were conducted showing protection against development of allergy in rural areas. Previously, we have conducted a large cross-sectional study in urban and rural southern China. This rural area called Conghua is not far from Hong Kong, but has a traditional agricultural farming environment. The farmers there mainly grow crops and fruits like lychee. They raise very few livestock, like pigs, usually for self-consumption. We screened over 17,000 children 5 to 8 years old, about 3,000 from urban Hong Kong and 14,000 from rural Conghua. Not surprisingly, our results show that the prevalence of current wheeze was about 4 times higher in urban Hong Kong than that in rural Conghua. And in our analysis, we have found several environmental factors that appear to exert protective effect against childhood asthma in this rural population. To further understand the underlying reasons for the urban-rural disparity of childhood asthma and allergies, we've conducted collaborative studies with researchers from Germany, Finland, and China, looking at the genes and protein expression of a variety of immune molecules in rural and urban children from these countries. As shown in this graphical abstract of this paper published in 2019, we found that asthmatic children express more pro-inflammatory genes and less anti-inflammatory genes when compared with healthy children. And ex vivo stimulation with farm dust can shift inflammatory gene expression towards an anti-inflammatory state. One of the major initiators of inflammatory pathway is the transcription factor nuclear factor kappa B or NF-kappa-P, presented as the as a yellow dimer in this graph. In the resting state, NF-kappa-B is isolated in the cytoplasm by its inhibitor, NF-kappa-B inhibitor alpha I-kappa-B alpha, encoded by the gene NF-kBRA. In response to stimulation of extracellular signals, I-kappa B alpha is ubiquitinated and degraded, allowing NF-kappa B to translocate into the nucleus where it can bind to response elements on pro-inflammatory genes and initiate their transcription. Therefore, I-kappa B alpha or NF-kBIA is recognized as an anti-inflammatory molecule by keeping NF-kappa B inactive and restricts its downstream inflammatory cascades. Previous studies have shown that polymorphisms of NF-kBIA result in decreased I-kappa B alpha gene and protein expression, leading to enhanced NF-kappa B mediated TNF-alpha production. Network analysis also reveals that NF-kBIA is a central hub in transcriptional responses of prevalent childhood airway diseases, including asthma and respiratory viral infection. Based on these previous findings, we went further and recruited random samples of controls and cases based on their answers to the validated APAACI questionnaire. The cases are asthmatic children who had wheezy attack during the past 12 months and physician-diagnosed asthma. We obtained blood samples from these children, processed the blood and extracted the peripheral blood mononuclear cells immediately and treated either without stimulation or stimulated with lipopolysaccharides, a cell wall component of gram-negative bacteria. Then we studied the expression of genes related to inflammatory signaling pathways by quantitative real-time PCR. We specifically chose genes of mitogen-activated protein kinase, MAPK, and NF-kappa B signaling pathways as markers of inflammatory response. MK1 and MK14 are key players of MK pathway, which initiate the pro-inflammatory cascades. While dual specificity phosphatases, DUST1 and NF-kBIA are negative regulators of MAPK and NF-kappa B signaling pathways, respectively. And there are two ways to interpret the results. One is delta CT. Here, CT means cycle threshold, which is the number of PCR amplification cycles required for the fluorescent signal to exceed the detection threshold. Delta CT is the CT value that normalized to the parallel measured housekeeping gene 18S. So delta CT reflects the absolute quantification, and the higher delta CT value actually means lower gene expression. In stimulated samples, another way to calculate gene expression is looking at the fold change after stimulation as compared with the baseline CT value in unstimulated state. This comparative method reflects the relative quantification. Here I've shown you in control children, comparing urban Hong Kong and rural Tsinghua under unstimulated conditions. At baseline level, rural children had consistently decreased expression of MAPK and NF-kappa B signaling related genes compared with their urban counterparts. However, the differences did not reach significant level, which may be due to the small sample size. Upon LPS stimulation, healthy children from the rural area had increased mRNA expression of the negative regulator of NF-kappa B signaling pathway, NF-kappa B initiator alpha, whereas among asthmatic children, LPS-stimulated PBMCs from urban children expressed higher levels of NF-kBIA than that of rural children. We then stimulated the cells with endotoxin. Compared with unstimulated state, if a gene is upregulated after stimulation, it would be coded in red, while blue color represents downregulation. As we can see in this heat map, in terms of fold change, ex vivo LPS stimulation substantially induced gene expression of NF-kBIA in healthy children from Tsinghua, suggesting a more regulated inflammatory response in the rural environment, and it could be due to the fact that rural children have been constantly exposed to a higher level of environmental endotoxin. Therefore, the current results are in line with our previous findings, showing that the inflammatory responses were dampened in children living in the rural area, indicating immune tolerance induced by continuous environmental exposure, while the immunoregulatory capacity of asthmatic children from the urban area can be restored by endotoxin exposure. Our findings suggest a pivotal role of environmental exposure in asthma protection through modulation of inflammatory signaling pathways. But what could be the driving force behind such changes? We still need to conduct more investigations to find out the answer. And this photograph was taken in one of our field trips to rural Chonghua. We would like to thank all our collaborators from Hong Kong, Guangzhou, Germany, and Finland. And thank you very much and I hope you all stay safe and healthy.